everyone's time. Again, like I said, welcome to this Region 7 Disaster Health Response Ecosystem Preparedness webinar, cases where EMS and toxicology intersect. Dr. McCabe here, and we'll get going. So Dr. Dan McCabe is a clinical associate professor of emergency medicine and pharmacy at the University of Iowa, division director of medical toxicology at the University of Iowa, and medical director for Iowa Poison Control Center. Dr. McCabe also serves as the co-lead for the Region 7 Disaster Health Response Ecosystem Chemical Specialty Team. In these roles, he is actively engaged in numerous aspects of improving the care for poisoned patients throughout the state. His area of clinical expertise is focused on improving the care of poisoned patients, including people suffering from adverse drug reactions, unintentional or intentional overdoses, exposures to chemical products, environmental hazards, or heavy metals, envenomation, clinical states of intoxication and withdrawal, and antidotal therapies. Through collaboration with providers and institutions throughout the state, he is focused on advancing the quality of care for all poisoned patients throughout Iowa. And with that, I will turn it over to Dr. McCabe.
Thanks, Tom. I appreciate it. And thanks everyone for being here. And thank you for Region 7 for allowing me this platform, this opportunity to speak to everyone today. So if anyone can't see my slides, please let me know. Tom and I had already kind of brainstormed this a little bit to make sure that everything was going smoothly. But if anything is not going smoothly, let us know, because then we can figure that out. So as Tom said, my institution is the University of Iowa and Iowa Poison Control Center. I have a lot of various hats, but today I'm here to actually talk a little bit about how our role in the Poison Center, our role as toxicologists, how we can help, how we can attempt to help EMS providers, whether it's preparedness ahead of time or in the moment of active patient care. So as you'll see when we go through this, the first third or so is kind of basic or generalities of poison patients in general. And then we're actually going to go through 4 distinct cases that are actually real cases and kind of explain how a poison center can actually help EMS boots on the ground kind of in the real as we go through cases. I have nothing to disclose. And so as Tom already brought up, the learning objectives here are how to, we're going to try to describe how the Poison Center can assist pre-hospital and transport staff in real time. So for all of our EMS providers, and then going to try to provide some case examples where EMS and the Poison Center helped or could have helped keep patients safe. So the big overarching theme that I'm trying to get across here today is for all of our EMS providers out there is, how can a poison center help you? How can we all work together to make patient care less stressful on our providers out there doing the hard job and better overall patient care for the patients that we're all trying to care for? Couple disclaimers. They're not financial disclaimers, but they're reality. I'm not an EMS provider. I'm not an EMS physician. I was an EMT prior to volunteer EMT prior to med school, but that was very limited on my scope and the time that I did that. We also, anyone that's in medicine recognizes how demanding of a job pre-hospital medicine is. And so we need to recognize that it's a very different clinical environment. And so we are always happy at the Iowa Poison Control Center and in Region 7 and the University of Iowa to help our EMS colleagues in any way we can. So as I said, we're gonna do a few slides on kind of general principles of poison patients in general. And you'll notice I commonly will use the word poison patients rather than overdose patients because poison patients come in a wide variety of different forms. And so a general definition that I like is poison patient is any person that has undesirable effects from any kind of substance that they were exposed to or ingested or injected or snorted or occupational, any of that stuff. And so that can include adverse drug effects of normal medications, environmental exposures, or yes, overdose, both intentional and unintentional. Those all can be lumped into a poison patient, in addition to things like envenomations, and the list can kind of go on for very, very, very long. When we think about poison patients, when we're speaking to non-toxicologists, a lot of non-toxicologists will immediately think of, well, toxicologists just think of things as toxidromes, like a constellation of symptoms or signs And essentially, there's this thought that toxidromes are the big part of our job. And they are, and essentially, but it's a little bit more nuanced than that. So these classic toxidromes that we all think about when anyone's going through school or in training about anticholinergics or cholinergics and sympathomedics and opioids and these different things that people really memorize or try to memorize, those are important to us as toxicologists because they help us anticipate what's going to happen next. But they're also, it's very important because as a toxicologist, when someone calls me and they describe the case for me and something is not fitting entirely within those buckets, then it actually will help me narrow a differential or narrow the substances that we're concerned about, and can really help me talk to whoever's taking care bedside. It can really help me help them with anticipation on what's about to happen in the next half an hour, minutes, anything like that. And so the toxidromes aren't just for us in toxicology to memorize and kind of get good on taking tests. They really do change a clinical scenario, and they change patient care on what is going to happen next and how to be prepared for it. So as this lecture is more focused towards our EMS colleagues, and so how do we take histories for EMS? Essentially, we don't need all the details, but there's some details that are a lot more important than others. And a big one is, well, what did they take? Right? That's the crux of it. Do we always need that information, or do we work without that information a lot? We do. It makes things a lot easier, a lot quicker if somebody can tell us what they took. And sometimes, as EMS providers are probably aware, sometimes EMS providers are the only ones that actually have that initial history. And so by the time, as a poison center or a toxicologist, if we get called by an ICU doctor that has no real history to go off of, that got handoff from an ER doctor, and that ER doctor maybe took a shift change, essentially that history is most important, or better, the quicker we get that history from somebody. Any time that we can, like actual time, similar to if we think about like a stroke patient or anything like that, time is important. Timing is very important for us because we can think about when someone is going to get sick based on what time they did this. And then the last thing is any effects that the patient is having now. Are they vomiting a lot? Are they completely unresponsive? Are they completely agitated and delirious? Any of those things really do help early on. Now, we think about, everyone in medicine understands what vital signs are, and we all understand that vital signs are one of the most important things that we need to assess in all of our patients. But in toxicology, I like to remind people that normal vital signs are not always reassuring. And this is because we have to interpret these numbers in the context of a poisoning. So if a patient, there's just some quick examples here. We won't belabor this point, but if a patient took 15, 20 different substances, or even a handful of 5, and they have normal vital signs, that to me is not necessarily reassuring. That means that essentially multiple medications are equaling each other out, and at some point, some of those are going to go away, and we're going to have grossly abnormal vital signs. So it's one of those that normal vital signs are not always reassuring. And similar to non-tox patients, if a patient is hypotensive and they have bradycardia or relative bradycardia, this is not a good sign. This is actually a portender of badness. And so a patient that's hypotensive that doesn't have a reflex tachycardia, I'm pretty concerned about early on. Patients that have hyperthermia or severe sweating, severe diaphoresis after any kind of overdose, or if we think that there might have been an intentional stuffing of illicit substances or packing of illicit substances, this is extremely, even if their temperature were normal, severe sweating after that or loud abdominal pain, I get very concerned about that. And then lastly, if someone were acidotic and we knew they were acidotic because we're going to transport them to another institution, if they have a normal respiratory rate, I'm actually very concerned about this patient, because a patient that is acidotic should be breathing faster. And so a normal respiratory rate in that situation is actually the opposite of reassuring to me. Now, a physical exam for toxicology, we get into the weeds and we go through all things like this, where we have a tox exam, and our tox exam essentially has pupils and mucous membranes, and we kind of go through peripheral perfusion. So we want someone to actually make sure that the patient's peripherally warm and all this type of stuff. But from a pre-hospital perspective, we trust our EMS colleagues that have taken care of a lot of patients. That what is abnormal to you? Is this patient looking completely normal to you on your cursory exam, or are there things that are really grossly abnormal? And let us know that as soon as possible. And lastly, I always like to make a point about and for when we're thinking about mental status, using the word altered mental status, no one really knows what that means. And so using words like alert or agitated, aggressive, or completely obtunded, those things actually help quite a bit more of us kind of painting the picture of what is actually going on with the patient. So there are a lot, Region 7 is 4 different states. All the states in there have their own workflow through the poison centers or their EMS and their EMS bureaus and departments of public health or Region 7. But all of us are working together to try to partner with our own within our own individual states. So the state of Iowa, we created a guideline that is actually posted in the website to the bottom through the Health and Human Services EMS Bureau, where essentially it was any EMS group can use them as quick refreshers of information that you could provide to a poison center and what the poison center could do for you. So it gives a little bit of background, kind of short and sweet of things to remember, and then also so that we aren't slowing down our EMS colleagues. They call us and we then ask a bunch of questions they weren't ready for, and then there's kind of this back and forth, essentially kind of giving some a preemptive, these are the things that we're probably going to ask. If you can get as much as you can for these, just kind of speed up the process. Well, the question becomes, well, but that seems like EMS is working harder for outgain for themselves or for the patient. In that same vein, actually, and this is on the guideline, that what poison control can do for that EMS provider and that patient is that we, in certain situations, can actually help anticipate what's going to happen in the next little bit and tell the EMS provider, hey, this patient's really sick. Maybe do you have bicarb available if this happens? Do you have what medications do you have? I would really be concerned about this happening relatively quickly. So essentially, then when things do go bad, they're kind of ready for it. They're a little bit more prepared. And then the other part that is kind of behind the scenes, our staff at poison centers across the country, very commonly when they get calls from EMS, will call the receiving hospital, and we'll actually tell that receiving hospital what they should kind of be prepared for when it comes to certain antidotes or certain treatments, or what kind of should be there when they hit the door. So we try to speed up that process, that the receiving hospital isn't sitting flat-footed on a patient when we say we really need a very specific thing from you. Now that we kind of got through these generalities, let's move into 4 specific cases where poison center, and these are all real cases that poison center. Poison center wasn't involved in real time. Other ones they were, but that'll kind of become clear as we go through. So the first case is a patient that was blue or cyanotic, that was not improving, so it was unresponsive to oxygen. And it's real story. This is actually published by our colleagues in Minnesota, and that's the PubMed ID in the bottom for the actual manuscript. But 31-year-old woman called 911 a couple minutes after ingestion of sodium nitrate. EMS was on scene very quickly. The patient was found at that time to be ataxic, cyanotic, tachypnic, diaphoretic, pulse ox of 94. So none of this is looking great. And this quick after an ingestion, this is pretty scary for all of us that someone got that sick that quickly. Within 20 minutes of EMS arrival, the patient had a seizure and mental status went to complete obtundation right before the seizure. Patient had jaw clenching. They couldn't bag the patient, couldn't intubate the patient because of jaw clenching. So patient then had a PEA arrest. There was an EMS physician on scene, and they did a surgical airways, EMS physician or a critical care paramedic. I can't remember the manuscript, but essentially they did a surgical, they criked the patient, and they noticed chocolate brown blood during the crike. The methylene blue, so the patient was transported to the ED extremely quick. And they got to the ED, and immediately everyone recognized what was going on, and they ordered methylene blue. But the issue was that this methylene blue, a lot of ERs, this is not within the ED. This comes from upstairs, and so there was some delay with getting that to the ER, and then the patient actually died, passed away. And if you look at the time from time of ingestion, this patient was dead within 45 minutes of the time of ingestion. Very, very, very quick acting. So I think a lot of us in toxicology would argue that toxicologists or our poison centers would be a player in helping our EMS colleagues. And the autopsy report showed this patient had a methemoglobinemia, methemoglobin level 84%. For people that aren't familiar with what a percentage means for methemoglobin, that means 84% of all the hemoglobin cannot have oxygen on it. All right, so only 16% is left to either have oxygen on it or to, and so this patient is going to be, is not going to have a good outcome unless we are really, really, really quick. Some background on sodium nitrite. So nationally, there's been an increase in incidence in the last couple of years on intentional self-poisoning by sodium nitrite. It's extremely easy to get in a variety of different ways. This is a younger population that has been doing this for self-harm, and there's been serious outcomes in the vast majority of these cases because it's very effective in what it does for harming. And most of these patients, the vast majority of them, actually have needed the antidote of methylene blue to keep them alive. There have been some EMS groups in the region and in the country that have actually, because of cases like this and the increase in incidence, have been talking about having for their local EMS, medical directors have considered things like stocking methylene blue on rigs or having an EMS physician bring it out, any of those types of things. And this is not my role to say whether that is appropriate for individual agencies. That's not my role here. But I would say that methemoglobinemia in these situations develops extremely fast within minutes, and the life-threatening effects can happen within 30 minutes. So also methylene blue takes a little bit of time to work. So even if it can't be given by pre-hospital, having the emergency department that's going to be receiving the patient know about this patient and know the absolute need for methylene blue as soon as they get there. Again, with if we can help set that up, if we can help do those phone calls, every poison center in America would be happy to help assist with that, because minutes really do matter. Honestly, seconds kind of matter in this situation. So the next case is a patient that is delirious, tachycardic, so their heart rate is going extremely fast, and they're also seizing. So this is a 15-year-old that took an over-the-counter medication due to a social media TikTok challenge, and this is a real thing that's been happening across the country for a couple years now. The parents found him confused, and then they called EMS. Once EMS arrived, the patient started seizing, and benzodiazepines were given. And the patient then continued to seize and was found when they got the patient on the monitor, had a wide complex tachycardia. So this is Benadryl. This is diphenhydramine. And I put this in the top right corner just to remind people that don't do toxicology poison center work all the time that diphenhydramine in high amounts has a toxicity very similar to tricyclic antidepressants. That tends, when I tell people that tends to simplify it for them a little bit. Diphenhydramine works very quickly, both the good and the bad. And it's always, every single year is always a top 3 to top 5 most common overdose in the United States. So this is I don't care where anyone's practicing, any ER, any EMS group, at some point you will be having some diphenhydramines overdoses. It's very anticholinergic, and the severe cases are not subtle, they're not delayed, meaning that these patients are going to start having bad effects quickly. Within 30 minutes, 60 minutes, these patients are going to be delirious, tachycardic, seizures, dysrhythmias. All those things can happen. In the sicker patients, that happens a lot quicker with. So it's not subtle. Now, the treatment for a very severe diphenhydramine patient is going to be based on the exam and the EKG. And you can notice that I put exam in red and EKG in blue because it kind of aligns with what's going on. So for someone that's really agitated, delirious, hallucinating, benzodiazepines are what we're going to be treating delirium, and at least for the pre-hospital setting. Same with seizures. We're also going to be treating those with benzodiazepines really aggressively. But because diphenhydramine, very similar to a tricyclic antidepressant, can cause wide complex dysrhythmias, it's due to something we call sodium channel blockade. We have to treat that with sodium bicarbonate, and bicarbonate pushes, so amps of bicarb. And so both the seizures and the QRS prolongation can be treated with that in addition to benzodiazepines, but we need an EKG. This is a big push for us in the poison center toxicology world of why we are pretty firm. Most of us have our opinions that these patients shouldn't be bypassing any hospital. We really need an EKG as soon as possible because these patients bypassing hospitals or being transported in a place without an EKG, these patients might not get to the big hospital, or so this really does matter. We need an EKG. We need the intervals very quickly, especially in sick patients. And if we were thinking about diphenhydramine, most people would recognize, oh, well, what I learned in school was that's anticholinergic, and we'd have something like this that is a mnemonic, a very classic mnemonic about kind of remembering that toxidrome of anticholinergic. And there's a lot of examples. There's tons and tons and tons of medications, plants, you name it, that are anticholinergic. Being anticholinergic is not rare in our society, from intentional, unintentional adverse effects, and anything like that. But with this list, a lot of people are going to be confused because they're going to say, well, this list that I learned in school didn't tell me about the life-threatening sodium channel blockade that's associated with this. Well, the reality is most substances are going to have a lot of various effects, and no mnemonic can be specific for any specific substance. So these mnemonics and all these algorithms, guidelines can only be as good as what they are, and they have to be general. And so that's really why we're here. We're here because this makes complete sense to us, because honestly, we take care of this all day long. Our poison center staff take care of this. I don't know how many cases a day they take care of this. And so this is why calling us early. There are certain medications that are going to cause different things, and we are prepared for it. This is what we do. So moving on to case number 3. We have a patient that is unresponsive and bradycardic. So a patient was brought to a local emergency department, a smaller hospital, after an intentional overdose. The patient was unresponsive there, was bradycardic down into the 40s with their heart rate. Patient got intubated and was then accepted to a larger receiving hospital. Of note, the poison center or toxicologist, neither were called prior to transport to the larger hospital. Patient was sedated on dexmedetomidine, and the patient had a very prolonged QT interval on their EKG that was not addressed, and the heart rate continued to be bradycardic. So during transfer, this then happened. The patient went into a torsade de pointe. So this is obviously not a good outcome. So if I can remind people, if you have a really prolonged QT interval on your EKG and you're bradycardic, this is not good. and we have to really pay attention to it, and we have to do some things for this. So this case was a case of a patient that took clonidine, a medication that is going to slow your heart rate down, methadone and ziprasidone. So two medications that are going to make you, well, all three are going to make you somnolent or obtunded. But methadone and ziprasidone are going to absolutely extend out your QT. They're some of the worst players for QT prolongation. So those three things together are going to put this patient in a really horrible situation. Plus, the patient has some electrolyte issues. All these electrolytes are down a little bit, which is going to worsen the QT even more. So for a QT interval prolongation, very different than a QRS prolongation. We treat those very different. What we need to do is we need to increase the heart rate. So this is the whole reason why when people are going to Torsades de Pointe, a lot of times we will electrically or chemically pace them. We will pace them out and get going in and out of Torsades de Pointe. We will get their electrolytes to normal because we don't want to have increase that risk at all. And then we're also going to remind people, we're going to give them lists and kind of walk through, do not give this for sedation, do not restart these medications. And so there are some real things that need to be reminded. And so it's another reminder that, again, something we do all the time, but for a transport team, I think that they probably would have been more comfortable if they or the initial receiving ED gave us a call, and most poison centers would have said, please, let's get the electrolytes normal before we transfer them. Let's get their heart rate up a little bit, things like that to prevent the torsades. All right, and then the last case we're going to touch on today. So this is a case of something in a barn. And as we are 4 Midwest states, I think that a lot of us are going to have kind of a guttural reaction to hearing about a case where someone got into something in a barn. So this history is a 24-year-old that ingested something in a barn. Doesn't really even matter if it's intentional or unintentional. But the grandfather found him vomiting, called EMS. EMS arrived. Patient was found unresponsive and apneic. And now the grandfather's vomiting. So now we have a couple symptomatic people on scene. And now the question is, what do we do next? So the 24-year-old, the main patient, continues to have emesis, vomiting, even though is unresponsive, but still stuff is coming out. Has bowel incontinence, having feces come out. Patient is severely diaphoretic, but a lot worse than normal diaphoresis. You can't get anything to stick on this patient. If you're trying to do some EKG stickers or tele stickers, they're not sticking. If you're trying to do tegaderm, it's not sticking. Essentially, nothing is sticking to this patient because they're so profoundly wet. Patient is bradycardic, and patient, because they're apneic and unresponsive, I think a lot of good providers are going to intubate that patient. They're not protecting their airway, and they're honestly not breathing. But when they intubated the patient, they noticed that there was excessive froth in the ET tube. So essentially, when they put the tube in, that tube was filling up with kind of some frothy liquid bubbles. So now what do we do then? And now what are we thinking at that point? Because this is pretty concerning, I think, for all of us. Well, this case, I think a lot of people here would recognize this is organophosphate poisoning. Right? And there's a constellation of symptoms depending on which organophosphate you have, but bradycardia, pulmonary edema, vomiting, diarrhea, diaphoresis, those are all pretty well known and well established to be organophosphates or cholinergic substances in general. And the treatment for this is extremely large doses of atropine. Most of the time, higher doses than what anyone has ever given before. It's not uncommon that small hospitals will run out of atropine for one patient. It's a lot, right? So the small doses we do in ACLS aren't going to cut it with this patient. And we use atropine both for heart rate, but then we also use it to actually kind of to dry up the pulmonary edema, the pulmonary secretions that are inhibiting the ability to oxygenate these patients. Then also we can use an antidote depending on the situation. The antidote that we can use is pralidoxine or 2-PAM, a lot of people will hear. And this can try to prevent, it's used to try to prevent any progression of neurologic effects for long-term outcomes. But another very, very, very important thing of cholinergic substances or organophosphates is that protective equipment is absolutely essential. It's pretty common that the bystanders can get symptomatic, or healthcare providers can become symptomatic from the off-gassing of the emesis or the stool or the physical contact, the transdermal. All those things can absolutely happen, and it's repeatedly been shown. And in bioterrorism, which we'll talk about, it's one of the most common things that we see. So if we went back to toxidromes, a mnemonic that most of us will use for a cholinergic toxidrome would be dumbbells, and most toxicologists or poison centers like this because the B's, it tells you what is going to actually kill the patient. What's the most deadly is that patient's lungs fill up with fluid, that's the bronchuria, and then their lungs don't, the alveoli don't open up well enough, so this is the constriction of the bronchioles, I guess. And then their heart rate will go down to whatever it possibly can get down to before death. And so essentially, it's good for providers to kind of think about the dumbbells because it will point us into the scariest things. The rest of this is the patients get wet and they have emesis and a lot of fecal incontinence and that type of stuff. But the other part of cholinergic toxidrome that we don't tend to classically talk about in a lot of textbooks, even though it's well known and well described, is that there's also another half of cholinergic toxidrome that is essentially all based on the paralysis, right, and fasciculations. And if people want to simplify it, they could actually say a cholinergic substance can actually work very similar to succinylcholine. And I know that all of our EMS colleagues would recognize what happens when you give someone succinylcholine. They quit moving and they have fasciculations during that situation. So there are tons of examples of organophosphates or carbamates or nerve agents, bioterrorism agents, sarin, tabin. So this gentleman on the right was actually the leader of the sarin gas attack in Tokyo, and there's a lot of data that's come out after that of how many people, bystanders, got kind of affected and all that type of stuff. But there are the bioterrorism agents that Russia has used, still using those things. There are a lot of cholinergic medications. So went through all this stuff for this case, but now we get back to the crux of the lecture. Well, how could a poison center help with this individual case, right? Well, the first thing is try to provide recommendations in the moment about what's going on. How can we help? Like, describe the atropine, and but a big thing would be reminding the people that are taking care of this patient on decontamination prior to getting to the hospital is absolutely essential. If they're not decontaminated prior to the hospital, they have to be decontaminated at that hospital, or else we're going to get a lot of patients. And within that, reminding people how important PPE is for this situation. Well, what else can we help with? Well, behind the scenes, groups like the one that we're all sitting in today, Region 7, or our poison centers, region response teams, you name it, the list goes on. All of our teams work a lot, very diligently, to create partnerships to prepare for these situations. All right, and we tend to know each other, and we tend to and with that, behind the scenes, we may know which hospitals have the antidotes. And so, reaching out to the different hospitals to see, can we ship them between, or should this patient get directly sent there? But then also, different states are different for the national stockpiles, what we call ChemPacks, that are the strategic national stockpile for chemical bioterrorism agents. And these are strategically placed around the country and throughout your state. And every state's a little different on who releases that. I know Nebraska's Poison Center has a big role to play in of releasing these or being part of that conversation. at Iowa, I know that we are not the ones that release it, but we would be immediately in contact with our state bureau, HHS bureau, for those conversations. So essentially, we can do a lot of behind the scenes work to try to smooth out the process of not just getting the patient to the hospital, but do we have enough antidote to take care of that patient and any other patients? And that takes time, that takes effort, that takes a lot of phone calls. So how can we help? We can help with a lot of that behind the scenes work. And if we kind of want to wrap up the end of this lecture, we're here for a Region 7 webinar today. And what have we done for Region 7? Well, for the Region 7 Disaster Health Response Ecosystem Hazmat Guidelines, if you go to the website, it's at the bottom. It has our chemical team, but we have a variety of resources on the website that are open for anyone to utilize. My colleague Kathy Jacobitz at the Nebraska Regional Poison Center, a lot of this is her doing. And I've been trying to help as much as I can. But we wrote 20 guidelines for hazmat related situations. And these hazmat guidelines are different than any one that we've ever found anyplace else. And so these are open, honestly, anyone in the nation can use them, but they were developed by Region 7. So we're going to go through one very quickly to kind of explain why they're a little different and how these can be kind of helpful for everyone that takes care of the patient, whether it's EMS before the hospital, the first hospital, transport teams, the secondary hospital, all those things, or the patients themselves. So since we're still kind of on this case for insecticides, nerve agents, we'll go to that one, and essentially it's all on organophosphates. In these guidelines, we have a background. We try not to go too far into the weeds, but we try to give someone a little bit of a description about what these things are and what's a mechanism and some routes that can cause issues. But then we go into the meat of how we can help the provider. And we talk about PPE and what PPE should be important for this type of exposure. Right? And then how to decontaminate these patients. And then next, we walk through what signs and symptoms that we are expected from this situation, and for different organ systems. And then for the organophosphate one specifically, we actually talk a little bit about essentially giving people reminders of the mnemonics of how we kind of think about these. For all these guidelines, we provide any diagnostics, any imaging, labs, or anything that would help the diagnosis besides clinical evaluation, and how often to do those, if there are any specific for those. And then the last part is the treatment. So what specific antidotes, what specific treatments that are very important for these situations, and we'll even give dosing. And these, again, are general guidelines, but they're focused for the hazmat scenario. And so I guess with that, I'll just leave it with, we prepare for these situations to support you. I think everyone recognizes that there's a ton of preparation behind the scenes for all these situations. So no one's alone in these situations. So give us a call, call your poison center whenever you think that they could help you, and they'll happily do that. So since this is an educational lecture, I did have one last slide on some buzzwords or some pearls quickly of some patterns to recognize, and maybe some treatments that we could think about. Okay. So if you have someone that has respiratory oppression and apnea, if it's a poison patient, a lot of times our treatments are going to be focused on things like naloxone, and if you don't have that, or if that doesn't work, intubation. I think most of us would recognize that. If we have a patient that, like one of the patients we discussed today, if they had a seizure and they also have a prolonged QRS or on their EKG or their tele, we're going to give benzodiazepines, but we're also going to give some sodium bicarbonate. If they are extremely agitated and hyperthermic, and they're a poison patient, whether it's stuffing, packing, or if that's just using amphetamines, or if that is using our prescription amphetamines, Adderall, any of those types of things, we're going to use benzodiazepines, and we're also going to actively cool these patients as soon as possible. If you have a patient that is bradycardic, their heart rate's low, and they have a really prolonged QT, we're going to provide a lot of different recommendations. We're going to get the electrolytes back to normal. We're going to avoid any medication that slows their heart rate down, so they shouldn't be sedated on things like dexmedetomidine. We're going to avoid anything that can prolong the QT longer, so no medications that we normally would use kind of throughout medicine. And then there's always the anticipatory guidance if we went into torsade de pointe of how to get it out of it, that I think a lot of EMS or ER ICU docs would recognize in general, right? So we're going to give some magnesium as a bolus, and we're going to defibrillate them, and we're going to paste them, whether it's chemical or it's transcutaneous or transvenous. And then lastly, the really scary thing for kind of a bioterrorism or a rural farm community area, it would be an unresponsive, bradycardic, wet, and there's some kind of concern for pesticide terrorism. And so this becomes very important. Of atropine is our life-saving antidote, but pralidoxine has a role. And then also the essential decontamination and personal protective equipment is absolutely essential in these situations, because we can get other people, yourself, sick if we're not thinking about that as soon as possible. And lastly, the worst thing that could happen to these patients or any of our providers that are pre-hospital or transport, the worst thing that could happen is unnecessarily a patient to decompensate during that transport. And so give us a call as soon as possible. We can try to help avoid that by providing anticipatory guidance. And I really highly recommend putting an unstable poison patient in transport without giving us a call, because again, we're just here to help. We're a free resource to anyone whenever you need us. And with that, I thank everyone. There's my email there. You can give me an email and we can talk about anything you want. I will stop at that point. I think we have about 15 minutes for some questions.
Fantastic. We do have some questions filtering in here, so we're just going to kind of go first come, first served here. First one up asks, says, we're a basic EMS service and the closest hospital is 15 to 20 minutes away. At what point or what protocol would be wise for getting paramedics to meet en route for an intercept?
That is a great question. You know, as we're four states that have a lot of rural areas. I think that'd be up to your medical director to kind of have some conversations kind of behind the scenes, and recognizing that we can make protocols or guidelines, but that individual case might vary from that a little bit. But I know that we have with our local EMS directors at my institution, that we've spoken about things like this with these exact conversations. But it is something worthwhile having that conversation ahead of time of if we have an intentional overdose and we can't do tele on scene or closely, is a paramedic that can do tele or an EKG, is that appropriate? But again, every agency's financial limitations, the staffing limitations, all that have to take, but it's worth having the conversation to see what's possible in your area. So I'd reach out to your medical director, and your medical director can also reach out to your state poison center to see if they can help with that too.
Okay. The next one, I'm actually going to kind of group two of these together, but we can take them individually. One asks about if poison control centers are communicating across state lines. And to that point, the follow-up is, so for example, would Missouri know what antidotes might be available in Arkansas for things like treating envenomations or anything like that? I guess it's just generally looking at what kind of communication is happening between poison centers.
A lot. To say it's that's an understatement. All of our poison centers, there are 55 poison centers across America. We all know each other very well. We all work together extremely well. We all hand off cases to each other all the time. So that means that when we have a patient that starts in one state, we will call the next state if they're transferred, or we will call the next state and hand them off. So we will literally transfer the entire case over to them. The directors, the managing directors, the medical directors speak quite frequently. And in those individual situations, if there's something in a region that's bordering on states, it is extremely common that the directors from both if not more states, surrounding states are on an email chain and a Zoom call very quickly after that. So it's one of those, if it was on the border of my state on an area that didn't have a whole lot, I'd be calling the state right on that border to see what's closest. I know that when we know about our antidotes in our state, I very commonly will reach out to our directors in the other states to know what they have also.
Okay. This other one here asks, what PPE is recommended for off-gassing for organophosphates?
Yeah, so it's in that guideline, this. So positive pressure or oxygen source or self-contained breathing apparatus. And we got all this information actually came from ATS. So the provider safety came from ATS SDR. So it's our national kind of standard. So if you wanted a specific for that, I would just go to this website and pull it up, and you could have that, but that's what's recommended.
Okay, a couple more coming in here. One actually is a suggestion, and a fantastic suggestion, suggesting that everybody puts the Poison Center number into your own phones. She mentions that their small rural squad has called them twice from the scene after everybody started putting it in their phones. And I'm going to throw in my own question here that I was wondering before I get to this other one here. I know poison centers control or collect data on everything. I guess I'm curious, like how often or what rate or any version thereof of how often is EMS calling poison centers from the field, or even during transport? Do we have an idea?
Those numbers are out there. I don't have them off the top of my head. Different regions are different perspective, and so I trained in other states, surrounding states, where we had different levels of EMS calling. We have had an increase in my state recently in Iowa, probably because we've worked very hard with our HHS colleagues to kind of put out the HHS guideline that agencies can use. And I've given similar lectures to like this at the EMS trauma state conference.
Mm-hmm.
But if EMS groups don't know that this is a resource, they're not going to call. So we do know it's not insignificant. It's actually a decent number, but certain places are a lot more. I will say at the University of Iowa, even though we have the tertiary care center in our town, a lot of our EMS colleagues, a lot of our paramedics will call, even though they only have a 10-minute drive to the hospital, probably because the toxicologists are there and we work with them all the time. But it depends. The number is actually quite a bit. So I would say if you have any question, just give it a call. I would also remind all of our EMS colleagues that once you make a case, we will continue to follow that case until the patient is completely safe, meaning that when they're at that hospital, we will continue to follow them in the ER. We will keep monitoring them. When they go to the ICU, we'll continue to monitor them. When they get transferred to the next state, we will hand that off to their state. So we a lot of times become the most longitudinal care that the patients have. So the earlier we get involved, the better.
Good. That's kind of what my thinking was with that. If we push EMS pushes early interventions for cardiac arrest, for stroke, for anything like that, pushing it for anything, any kind of poisonings, accidental ingestions, any of that kind of stuff, overdoses would be just as beneficial.
I would say there have been a decent number of cases at our own personal poison center where since EMS called us and we have the history from the very first EMS provider, and then the patient goes unresponsive and there's kind of handoffs in the hospital, or there's not family involved. It is not uncommon where the poison center has the only real documented initial history, and that was all provided to us by EMS on scene. And so that can be very helpful when we're thinking about, well, where are we going with this case? Because we really have the data and we know what actually happened 3 days ago.
Absolutely. Let's see here. Got a couple more coming in. So, as a BLS provider, how can I better help my medic or the receiving facility to better treat a patient with toxic inhalation, ingestion, etc.? What are some resources that you may be able to give for BLS providers to better research on our own?
I love that question, because it comes from someone that obviously just cares about the patient. So for BLS providers, I would say honestly, the big thing would be to call early, and even though it can't be a long lecture that our staff do, our staff can still within 30 seconds or so kind of teach something or kind of provide you with guidance. For education, there are a wide variety of things. Something I would definitely recommend considering is there's called an Advanced Hazmat Life Support, which is AHLS. It is a national body. It's actually invented by University of Arizona. I will put a little bit of plug in that Region 7, a big part of what we do on the chemical team is we actually put on a course, at least one course. It sounds like at this point, multiple courses a year are happening through all of our 4 states,
Mhm.
where these are directed towards most people that come are EMS. Pharmacists, some ER docs will come, but the vast majority of people are EMS. And Region 7, if you're interested with it, there was a grant. I think it's still going on that some of it can be paid for. But the Advanced Hazmat Life Support, if you go to their website, they have numerous different types of class. They have online classes, they have short classes, they have multiple day classes. That is something that because that's focused more towards the meat and potatoes of how do I care for these patients. So I'd highly recommend those courses.
And I will say, I'll throw the plug in there as well, for those AHLS courses that we put on there, and what I've seen from the ones that I've helped put on. Um, don't get hung up if you're if you're a BLS unit or anything like that. Coming and getting the information and doing all that is more important than worrying about certification side of things. There's still a lot that can be gained from those classes, whether you are a paramedic or a nurse or not. That shouldn't matter. It's come and get the information.
Yeah, I couldn't agree more. I know that multiple of my colleagues are probably on here. I teach them with me because we teach a couple a year. And the pre-hospital people are the people that we really, really, really want in those classes because they're the ones that have to really move quick on these cases. So
Mhm.
absolutely, the certification should be less important for those people because it's still a fantastic course for all levels.
Right. Let's see here, a couple more questions. Let's see here. One talks about if you have an issue with an ET tube becoming plugged with frothy fluids or etc., could you use an eye gel or king tube, something that's within a BLS scope? Would that be advisable to try?
Yeah, it's hard. It's hard to give a general swath of recommendation for that situation because the individual patient is the individual patient. There are so many organophosphates and there are so many bioterrorism agents. Some don't do that at all. So some of our new bioterrorism agents don't really cause the pulmonary edema as much, and so these patients just essentially become apneic, and you see the neurologic stuff. A lot of our older school pesticides have a lot more of the pulmonary effects and then kind of everything in between. So the reason why when I'm giving these lectures, I harp on the frothy sputum when you put an ET tube in is just to remind people that I'm an ER doc, right? So I've been trained that you have to protect the airway, but in organophosphate poisoning, sometimes putting the breathing tube in, it's not wrong. It's just it hasn't fixed the problem. The problem is that the liquid is actually within their lungs itself, and you can't suck that out. You have to dry it out with atropine. And so a king or eye gel is fine if that's all you have and the patient's apneic. Like do what you have to do. The reality is if the patient's apneic and paralyzed, they're going to need an advanced airway at some point, sooner rather than later. So I'm not against it. The reality is we kind of need to do it as soon as possible. Also, the reality of that situation is if you're going to have an eye gel and there's going to be sputum kind of coming around there, remember that all the stuff that's coming out of their mouth is also going to put anyone else at risk. So PPE is paramount.
Good deal. And then the last one that we have coming in here, as we're nearing the top of the hour, it says, are there any guidelines for using outdated bicarb in emergency or mass casualty situations?
There's no data, but I love the question. No, there's no data that I'm aware of. Is bicarb a lot of our antidotes? A lot of our antidotes are kind of cheap, in toxicology or poison center in general, and so there's a lot of subsidization that happens, and there's a lot of different things that essentially they'll come off the market. So occasionally bicarb goes on shortage. It would be up to the individual agency and the individual institution with their PNT on if they allow that or not. I know that at my own institution, when certain medications are no longer being made or on shortage, we put this in front of our PNT committee for the University of Iowa, and essentially people vote on if we're allowed to use expired medications because we don't have any other choice. So it'd be one of those things I would absolutely talk to your medical director about and run it up the flagpole of their institution to see if it would be allowed. But there is no specific guidelines. There are individual institutions when we have these conversations. We have specialized pharmacists that essentially will look through all the data for that specific drug and to try to come up with some kind of, but there's no guideline. It's just a recommendation from that individual person.
Okay. That's all. Kathy, looking forward to a great AHLS course, of course. That's all the questions that we have right there, and we're right here at 1:59, so we'll respect folks' time. If there are further questions or anything that folks can think of, I would say feel free to reach out to us at the R7 or even to Dr. McCabe. We appreciate everybody taking the time to join us today and appreciate Dr. McCabe with this presentation. So thank you all very much and have a good afternoon.
Thank you all.